It is not only hormonal therapy that has been an area of progress, but recently, sort of under the radar, a very interesting study has been completed showing radionuclides can effectively treat bone metastases. And our next speaker is Joe O'Sullivan, who's a radiation oncologist from Ireland, and he'll address this topic.
Thanks, Dr. Chabner, and thanks to the STO for inviting me to be on the faculty. Thanks also for putting me just after Johan, because he's not really a hard act to follow at all. So we'll do our best. So I'm hopefully going to talk to you about a class of drugs which I think will hopefully become more useful in the lives of men with prostate cancer. So I'm going to give you a little bit of a history of radionuclides and prostate cancer, and then describe some of the recent trial data which is emerging. So this is data from the TAX-327 trial, which Johan also mentioned, which was the large randomized phase 3 trial, which demonstrated for the first time survival benefit for docetaxel when compared with mitoxantrone. But one of the interesting facts that came from this trial was it was one of the first studies to really assess these patients properly with both bone scan and cross-sectional imaging. So it was a really large data set of what was the state of disease in men with what we defined then as hormone-refractory prostate cancer, but certainly progressive disease following castration. And in a metastatic population, it was noticed that about 90% of these men had bone metastases. So significant majority of men in the study, in all the arms, had bone metastases. Also, what's become apparent as well, that there's a significant non-bone burden, but I think the most important message here is that there's a very big predominance of bone-related disease in prostate cancer. So 90 to 100% of men who die from prostate cancer will have bone metastases. And for the majority of these men, bone is the only significant site of metastases. It's what causes their symptoms, pain, fractures, etc. And likely it's what causes their death in many cases as well from bone marrow failure. So for that reason, for many years, bone-targeted therapy has been very important in prostate cancer. And bone-targeted therapy has been particularly important with regards symptomatic benefit. But I think emerging evidence is suggesting that there may also be a survival benefit for bone-targeted therapy. So what bone-targeted therapies are there? Well, the two large groups would be bisphosphonates, and in prostate cancer, that essentially means zoledronic acid, and also radionuclides, which I'll come back to. But obviously also in recent years, denosumab, and previously ZD4054, which has shown less promise than was hoped. So radionuclide therapy. Well, history of radionuclides. In 1900, Pierre and Marie Curie first isolated radium. It was the first radioactive isotope to be isolated and demonstrated to have activity. And in 1903, they won the Nobel Prize for that discovery. Here they are heading out on a picnic to celebrate the Nobel Prize. And by 1906, radium was being used to treat cancer, and radium rods were being used to treat cancers, for example, vaginal and cervical cancers. So it was a very rapidly developed technology. The first time radioisotopes were being postulated as possible treatments for cancer was in the mid-1960s, and radioactive phosphorus was proposed as a treatment for prostate cancer metastatic to bone. Here's a report from The Lancet. Strontium-89 was really the first agent which was licensed, and it was first tested in vivo back in the 1940s, but first reports of efficacy in patients was early 1970s, and then it was an investigational drug late 70s in the States, and received FDA approval for the treatment of painful metastases in prostate cancer in 1993. So a little bit about radioisotopes and radioactivity. Well, the two main types of particles which are emitted from these type of isotopes are beta and alpha. And beta being the most common type used therapeutically. And a beta particle is essentially a high-speed electron which is emitted from the nucleus of the atom. And this is what causes ionization, and this is what causes DNA damage and hopefully causes therapeutic effect. Alpha particle is a very much larger particle in atomic terms, and it represents the size of a helium nucleus, and it's a charged particle. So when you look at the penetrating power of these type of particles, first of all, alpha particle is stopped very easily by even a sheet of paper. So alpha particles have very, very low rates, low distance of penetration. In fact, alpha particles, when used clinically, will have penetration of one or two cell diameters sometimes, but up to 100 cell diameters. Whereas beta particles, you will need a little bit more shielding to protect yourself from beta particles, and for that reason, they also have a little bit more penetrating power in tissue. And we're talking about penetrating power in the therapeutic arena of 1 to 2 millimeters. And that then compares with X-rays and gamma rays and neutrons, which are the most penetrating. So this is just to give an idea of the type of radio protection that's required for these type of particles. So what do we mean by bone seeking? Well, and the isotopes that are most useful clinically in prostate cancer are bone seeking radionuclides. And what do we mean by bone seeking? Well, here's somebody's bone seeking. Here's a list of kill cat, new owner, peace and earth, bones. So this dog is bone seeking. But by bone seeking, with regards to radioisotopes in prostate cancer, we're talking about two broad categories of agent. First would be analogs of calcium, because as we know, prostate cancer bone metastases in general have an osteoblastic phenotype. And although we know the pattern is a lot more complicated than that, in general, a lesion which is visible on bone scan is likely to take up calcium more avidly than normal bone. And then the other broad category is where the isotope itself is not directly attracted to bone, but by attaching it to a phosphate or usually a bisphosphonate, it becomes attracted to bone for that reason. And here are the two categories. So the most commonly used calcium analog is Strontium-89, and then radium-223 or alpha-radon, which I'll come back to, is also a calcium analog. So these are drugs which don't really need to be, you don't have to bind them to any particular agents or molecules in order to attract them to bone. Samarium-153 is the most commonly used agent, which is attached to phosphate, but other agents would be rhenium-186, 188, and also phosphorus-32. So these are drugs which require some form of labeling with bisphosphonate in order to be attracted to areas of high bone turnover. So what do we know about bone-seeking radionuclides when they're used as single agents? And this certainly has been, up till the last few years, been the most common use of these drugs. We have level 1 evidence, at least 6 randomized controlled clinical trials, most of them conducted during the 1990s, which had demonstrated that these agents really are quite good analgesics. The two most tested agents are both beta emitters, Strontium-89, the calcium analog, and Samarium-153, attached to bisphosphonate. And so there's very, very strong evidence that these agents are good way of controlling pain, especially multiple sites of pain. Remember, these randomized trials were long before the advent of zoledronic acid, and certainly long before the advent of routine chemotherapy in prostate cancer. So we get pain response rates in the order of 60 to 70% for these agents, for these men with multiple pains, about a 60 to 70% pain response rate. We know that when you try to dose escalate, the limiting toxicity is hematological. And in general, it's thrombocytopenia. So when you try to push the dose of these drugs up in order to get maybe perhaps better activity, you come up against thrombocytopenia in particular. And also, it's pretty well recognized that these drugs, while they did demonstrate quite a lot of evidence for benefit in pain control, they were not really widely used. And there's a lot of reasons for that, both social and political for that, but we can discuss over a beer sometime. So really what I want to concentrate for the rest of the talk is the concept of using these agents with more novel approaches. So using them in settings other than as a single agent. And there's 4 broad categories. One is to combine with chemotherapy. Secondly is to give these drugs more like in a chemotherapy in a cyclical fashion in repeated administration. Thirdly, to try and escalate the dose. And finally, then I'll come back to using alternative particles, alpha particles. So the first time that radioisotopes combined with chemotherapy were shown to be of potential benefit was from Su-Ming 2 in MD Anderson. And this was a small randomized trial of metastatic hormone-refractory prostate cancer, as it was then known. And these were patients who had been given a course of induction chemotherapy with chemotherapy that would be quite unfamiliar to us at this stage. So a combination of ketoconazole, doxorubicin, and that was alternating with estromustine and vinblastine. So patients who survived that and who actually responded to that were then randomized to either receive no further treatment or to receive just doxorubicin follow-on treatment or doxorubicin plus 1 injection of strontium-89. Now, the primary endpoint of this study was time to progression, but they also looked at survival and PSA response. And although it's a very small study, it did show a significant survival benefit for the patients who received 1 injection of strontium. And the difference was 27 months median versus 16 months. Now, of course, a very small trial. It wasn't powered to detect survival benefit, but I think the difference is quite stark. This group here are the patients who progressed following the induction chemotherapy. So the comparison is between these two here. So that was the first suggestion that combining chemotherapy with radioisotopes might be of benefit. Since then, there have been quite a few trials, and here's just a summary of the published literature on radioisotopes combined with chemotherapy. And these are really mostly a combination of samarium with docetaxel, but one study here which combined rhenium-188 with capecitabine, which is a Dutch study. And these are really phase 1, phase 2 studies looking at toxicity and early signs of activity. And some of these studies are now progressing to further stages. What comes out mostly when you combine chemotherapy with radionuclides is that you get increased, not unsurprisingly, increased hematological toxicity. So the other approach then, as well as combining with chemotherapy, is to give these drugs more like a chemotherapy, so in cycles. And the first really signal that this type of approach might be useful was from Holger Palmito in Bonn. He, again, very small randomized trial, 64 patients with very advanced disease, patients who were very symptomatic, patients with multiple bone metastases, progressive disease, and they were treated with a shot of rhenium-188, which is a beta-emitting radioisotope. So they had 1 injection then, which was either repeated 8 weeks later or no further treatment. So patients were randomized to receive a further injection of rhenium-188 or no further treatment. And they were looking at pain palliation as the primary endpoint, but also looked at survival and PSA response. And interestingly, again, very small study, not even close to being powered enough to look at survival, but did show a significant difference in progression-free survival, but certainly provocatively an increased overall survival. The median survival in the patients that got just one extra treatment with rhenium was 12 months versus 7 months. I think this type of survival, median survival, gives you an idea of the type of patient that was in this trial. These were very, very advanced disease, very symptomatic patients. And again, pre-chemotherapy era. So what about combining those two concepts, combining chemotherapy along with repeated administration? And this is a study that we've just recently published from Belfast called the TAXIUM trial. And this is where we used a bone-seeking radionuclide called rhenium-186, which has very similar characteristics and uptake to technetium. So here's a patient who's had a technetium bone scan showing multiple sites of metastases. Here's the same patient a number of weeks later following a therapeutic dose of rhenium-186 HEDP, showing really very good correlation between where the metastases are present. So this was a study for patients with progressive metastatic castration-resistant prostate cancer, and a collaboration with colleagues in Amersfoort in Holland, and funded with unrestricted grants from Sanofi Ventus and Tycho Mallinckrodt. And this, the idea was a schedule escalation study. This was the final schedule that we came up with, which was 3 docetaxels followed by an injection of rhenium, 3 more docetaxels, and then a further rhenium. And then if patients were fit and well enough, they could continue with further docetaxel if it felt appropriate. But we started off with 3 cycles we started off with just 6 cycles of docetaxel with 1 cycle of rhenium, and then built up in 4 dose levels. So in all, we got 14 patients recruited between here and Holland. We reached dose level 4 without encountering any dose-limiting toxicities. We defined dose-limiting toxicities as grade 4 hematological toxicity or grade 3 lasting more than 10 days. And we really had to stop this dose level, not because we reached toxic levels, but because the supply of rhenium-186 dried up. The production finished in Holland. But we're now moving towards a randomized phase 2 study using rhenium-188, which is rhenium-186 is very, very similar drugs. It's rhenium-186's little sister. So we'll be using that hopefully over the next year. So what about dose escalation? Well, as I said, dose escalation is limited by hematological toxicity. So when I was working at the Marsden, we did a study looking at using peripheral blood stem cell transplant to facilitate dose escalation of radioisotopes in metastatic prostate cancer. So patients with progressive disease who were good performance status and who were not transfusion dependent were treated with first of all, we harvested their peripheral blood stem cells. So we stimulated with GCSF, harvested stem cells, and then at least 2 weeks later then we treated them with a very, very high activity of rhenium-186. In previous studies, the maximum tolerated dose of rhenium was in the order of 2,000 megabecquerels. But in a phase 1 study, we showed that we could get away with 5,000. So this led to this phase 2 study. So then patients were then reinfused with their stem cells after 14 days. It showed stable disease or partial response in the majority of patients, but about 20% of patients were progressing. So certainly it was showing activity, and there were some long-term survivors from this study. Some interesting bone scan response as well, PSA 35, bone met, PSA 0.5. This is after 3 months with no other therapy, apart from continued hormone therapy. And median survival in the order of 22 months, but some long-term survivors. So the last part of the talk then is to concentrate on this exciting new agent, alpha-radon. And alpha-radon, or radium-223, is an alpha-emitting drug, the first one to be used clinically. And as a reminder, the alpha particle is the nucleus of the helium atom, which is what is released in radium-223 as part of the decay process. And this is the phase 2 study of radium-223 in metastatic castration-resistant prostate cancer. And this was a randomized study showing, published in The Lancet a few years back now, and this was 4 cycles of radium-223 in a phase 2 environment, and showing that changes in alkaline phosphatase were significantly more common in the patients receiving radium compared to placebo. So a signal of activity in this bone-dominant disease. And also showing that there were some PSA responses. Interesting, it also suggested a potential survival benefit, which, as we've seen many phase 2 trials which have shown this, but the phase 3 hasn't lived up to that promise, but this is the exception to that rule. So that phase 2, the signal from that phase 2 study showing activity led to the large randomized trial called ALSYMPCA, which is demonstrated here. This was a randomized trial in men with progressive metastatic castration-resistant prostate cancer who had minimal soft tissue disease. So in order to get into the trial, patients needed to have no single solid extraskeletal lump more than about 3 centimeters. So essentially bone-only disease for most of these patients. They could have been either pre or post-docetaxel. In the trial itself, it was advised that patients should really have docetaxel unless they refused or were not fit for it. And they needed good performance status. But very importantly in this trial, patients needed to have bone pain. They needed symptomatic bone pain. So either patients who had required palliative radiation for bone pain or requiring opiate-level analgesia for bone pain. So this was a symptomatic group of patients. So the patients were randomized 2-to-1 alpha-radon versus placebo, and they received 6 cycles of alpha-radon at 50 kilobecquerels per kilogram versus placebo. And then they were followed up for overall survival being the primary endpoint. Now, the results have not yet been published, but this is in the public domain, so I can show you this. And this is a press release from Algeta, who are the company who make alpha-radon. And it shows that the interim analysis which was announced during the ASCO meeting, not actually presented at ASCO, but announced as a press release during the ASCO meeting, that the interim analysis had shown a survival benefit, and that patients who had received placebo should then be offered a real drug. So this, again, is in the public domain. Overall survival was significant, with a median overall survival was 14 months for the alpha-radon patients and 11.2 months for the placebo patients. Very little toxicity, certainly when you compare with chemotherapy, very, very little toxicity from alpha-radon, and very little hematological toxicity as well. And as Johan said, the peer-reviewed results are on the way soon and likely to be presented in Stockholm in a few weeks' time. And Belfast was the biggest single recruiting site to this study, so we feel a certain ownership of this data as well. So I wanted to finish up really with just one case history just for interest's sake. This is a chap, 82-year-old fellow, who will be known to some members of the research team in the audience here, who presented back in 2006 with extensive bone metastases, PSA 42, and with a Gleason 7 tumor. and started Ellie George agonist therapy with good response, and as is fairly typical, starts developing some resistance to Ellie George agonist therapy. Throw in Casodex, throw in stilbestrol with some responses, and then he progressed, and it was referred to myself when he started developing symptomatic progressive disease, which was resulting in quite a lot of pain. So we enrolled him in the Alzheimer's study, and he received 6 cycles of treatment, at the end of which his PSA had continued to rise, and in fact his pain had continued to evolve. So we found out following the interim analysis that in fact he had received placebo. So we then, as his pain was still quite difficult to control, we gave him 1 treatment with samarium-153, and PSA is now 0.5. So I think this just to demonstrate that these drugs are active, and there's no doubt that they do more than pain control. Obviously, one example. Here we go. So I say pain. So really, where will these drugs be used? Currently, this is the Howard Chair's model of disease progression in prostate cancer. And normally, here at the end is where we use radioisotopes, where patients are symptomatic, where they've got bone pain. And usually it's, when we use them like here, as was the tradition with samarium and strontium, it's really too late. Patients are already probably developing marrow failure, and they're really missing the chance of benefiting from these drugs. The evidence is suggesting that we should probably use them here at the beginning of castrate-resistance disease in the presence of bone metastases, and probably should be using it in a repeated administration scheme. Particularly, I think radium-223 has shown us that. But there may be also a role for using it earlier in the condition, and perhaps we can discuss this at the round table. So in summary, I think that there's increasing evidence that bone-seeking radionuclides can modify disease history in castration-resistant prostate cancer, and that there may be that there is a survival benefit when used appropriately. I think combining these agents with chemotherapy or other agents has merit, and I think we need to be thinking along the lines of those type of studies. And also, I think there's no doubt that alpha-radin will have a role in metastatic castration-resistant prostate cancer, but exactly where it fits will be really quite a difficult thing to tease out. And research questions which come from this, we don't know much about the dosimetry of alpha particles. In fact, it's very difficult to know how something which has such a very, very short range of radiation actually impacts on the disease bulk, which it clearly does, because we get PSA responses, we get bone responses, we get survival benefit. But the radius of radiation is very, very short indeed. I think there's certainly, having heard some of the earlier discussions, there's certainly a role for combination with PARP inhibitors and also with platinum and docetaxel. And there's a lot of scope, and certainly the company Algeta are putting a lot of effort into labeling of these agents, trying to have more tumor-specific labeling of radium-223. But the optimum schedule and whether we can use them earlier in disease, I think it's very uncertain about that. A lot of research is going to be required, and a lot of thinking about how we design those trials. So thank you very much.